How's it going, everyone? Today we're going to continue our conversation over the control of cardiac output, and we're going to talk a little bit more about the relationship between cardiac output and preload. So we talked about the Frank-Starling mechanism known as the cardiac function curve, where a increase in preload will increase cardiac output, while a decrease in preload will decrease cardiac output. Today we're talking about the opposite, where now the central venous pressure is going to be the dependent variable and is going to be impacted by cardiac output. And so that's what we sort of meant when we were discussing the differences between determinants of versus determined by. And so today we're going to talk about this vascular function curve and talk about how preload is determined by cardiac output. So in order to first look at the effects of cardiac output on preload and central venous pressure, we have to see first, what is the pressure going to be without cardiac output? And so in order to start the curve, you need to look at, well, what is the pressure going to be when there is zero flow, cardiac arrest, when the heart is not providing the pressure to circulate blood throughout the circulation? And that would be the static pressure, just the pressure of the blood itself when there isn't any work, when there isn't any blood flow coming from the heart. We also need to understand the difference between arterial and venous compliance and what role that's going to play in this relationship. And so down below, we could see that venous compliance is 20 times greater than arterial compliance. And remember, the formula for compliance is going to be delta uppercase V over delta P, meaning a change in volume over a change in pressure. So if we're trying to, let's say compare the compliance between the venous circulation and the arterial circulation, if 1 millimeter of blood raises arterial pressure by 1 millimeter of mercury, it would take 19 milliliters of blood to raise the pressure by that same amount. So again, that venous compliance is a lot greater, meaning that it could take on, a same amount of blood without the same increase in pressure. There would be less of a pressure increase with the same increase in blood volume. Let's sort of describe what would happen as far as pressure and blood volume is concerned if the heart stopped working. So if we look to the upper left-hand corner, this is the normal control state here, where the heart is pumping out a flow, that QH, the flow of the heart, is equal to 5 liters of blood per minute, right? And that blood is pumped into the arteries. The arteries have a certain compliance, represented here as uppercase C, lowercase a. The mean arterial pressure in this case is going to be 102 mmHg. And there is a blood flow, arterial runoff, that's that QR, the flow running off from the arterial section through the capillaries, or through the arterioles, through the capillaries to the venous circulation, of the same value as the heart. So whatever is being pumped out of the heart is being pumped through the arterial side and then being pumped through the venous circulation, right? The venous pressure is very low, 2 mmHg, because remember, the compliance of the venous side is a lot higher. So we're not going to see large pressures. This is a low pressure part of the circulation. And so, if we want to calculate resistance, we take the differences in pressure, pressure 1 over pressure 2, divided by flow, and so that gives us a resistance of 20 mmHg. So basically 5 liters of blood are being pushed through a resistance of 20 mmHg, and then we have all of the pressures here in this control state. But if the heart stopped beating, this would then turn the QH to 0. This is cardiac arrest. The heart is stopping. Well, what's going to happen is that the blood flow that was coming out of the heart right before the cardiac output went to 0. Well, remember that the elastic properties of the arteries, that's going to store some of that potential energy, and then that recoil is going to allow for that blood flow to continue shortly after the heart stops. So what we see initially is that, the blood flow, that arterial runoff is going to be similar, right? So this happens at the very beginning, and we see the pressures and the flow, the runoff of both sides of the circulation are relatively the same. But again, the heart has stopped beating, so that is not going to continue. So what's going to happen is that then the volume of blood in the arterial side is going to start to go to the venous side. And so since volume of blood in the arterial side is decreasing, so is the pressure in the arterial circulation. And so since that blood volume is now heading into the venous circulation, we're going to see that venous pressure start to increase. And so you may notice that the pressure is not increasing to the same degree. Remember, the veins are more compliant, so they're able to take on this large quantity of blood volume without the same increase that we saw, or the same level of pressure that we saw in the arterial circulation. But still, blood flow is going to begin to come to a halt because the pressures in the venous side are then going to match the arterial side. So now, as the heart stopped and blood went from the arterial circulation to the venous circulations and pressure started to reach the same, then the flow of blood throughout the entire circulation is going to become zero, right? So we've hit an equilibrium, which is equal just to the static pressure of blood itself. And so ultimately, the venous blood volume and the venous pressure has increased because when the heart stops, the arterial blood is going to start to make its way into the venous circulation. And since the venous circulation is compliant, it's going to hold on to that large quantity of blood volume. And ultimately, the flow of blood here would come to a halt, if the heart entered cardiac arrest. So now let's talk about this vascular function curve, right? Notice how cardiac output is our independent variable and it is affecting our central venous pressure, our preload, right? Here we see point A on this graph is a normal steady state cardiac output around 5 liters per minute. Point B would be cardiac arrest, just a liter of blood being pumped out. This point right up top, that is just the static pressure of the blood when cardiac output is at 0. And so basically what you see from this graph is that cardiac output in filling pressure, central venous pressure, or preload, however you want to call it, are inversely related. And so as the heart pumps out more blood, more of that blood is entering the circulation. And as more blood enters the circulation, more of it is going to be stored in those compliant veins. So if you pump more blood out into the peripheral circulation, more of that blood is going to find its way towards the venous circulation, and therefore that blood is not going to make its way back to the vena cava. It's not going to make its way back to the right atrium, right? So that's what we're seeing. An increase in cardiac output would decrease central venous pressure and decrease preload because of the compliancy of the veins, right? And so at cardiac output max, if nothing else is adjusted, right? And so obviously, we're going to talk about in a sec how, the body sort of overcomes this. But if cardiac output's at its max and nothing is adjusted, central venous pressure is going to fall to critical levels. And then the pressure inside the veins, inside those big veins, are going to decrease and even become negative, which means that they are going to collapse. And that would prevent cardiac output from raising beyond this max level. Now, of course, we all have a cardiac output max. And when you go on a VO2 max test, you're going to reach your cardiac output max more than likely, right? If you're really pushing it 100% effort. So later on in the lecture, we're going to talk a little bit how our bodies are able to overcome this and how we can keep up cardiac output and preload by a couple of different mechanisms. Ultimately, venous blood volume and therefore venous pressure is highly dependent upon the level of cardiac output. And as we just saw from the vascular function curve, there is an inverse relationship between venous pressure and volume, and therefore cardiac output. And again, this is due to the translocation of blood to and from the arteries and veins. And so, again, if we sort of draw it out here, right, we have the heart, right? So this is the left side of the heart. I know, great drawing here. And then we have the right side of the heart, right? Ultimately, the heart pumps out that cardiac output, right? A certain amount of blood. Let's say normally 5 liters per minute, right? And so that's sort of what you're seeing right here at the beginning, this normal steady state of cardiac output, right? And so what happens is, that blood flows from the arterial side ultimately to the venous side, and that's what QR is, right? That's the arterial runoff. That's how much blood is going through from the arterial side to the venous side. And under normal conditions, that should be close to equal, if not equal, to the cardiac output itself, as we saw earlier, right? And then that blood flow will make its way back to the right atrium, right? But as we saw earlier, if we cut off cardiac output, right, ultimately what we're going to start to see here is less and less volume of blood and less pressure of blood in the arterial side. And then we're going to see more and more blood make its way into the venous side. So as cardiac output drops, we see this delta P, this pressure difference. Remember, the flow is going to be determined by the pressure starting and the pressure ending, right? So this is going to start to become near zero, right? And so as cardiac output stops, the blood flow throughout the body is obviously going to stop. And that's why, again, that's why a lot of times we substitute cardiac output for flow itself. And remember, now this is a problem. If blood flow stops, obviously, this is going to be a huge problem. And we have a fixed amount of blood. So ultimately, if we want to overcome this, right, if we want to be able to increase cardiac output without a drop in preload, without a drop in central venous pressure, we're going to need to figure out a way in order to fix that, because again, we have a fixed volume of blood. So now let's talk about when you do have changes in blood volume. And again, these aren't necessarily like normal changes. In addition of blood volume would be a blood transfusion when you're adding blood to the already existing volume of blood. And then hemorrhage would be a loss of blood, right? So typically throughout the day, hopefully you're not losing large quantities of blood, but let's just talk about the effects of blood volume on cardiac output and central venous pressure. Obviously, if you increase blood volume, you increase cardiac output, and therefore, the pressures within the circulation, right? So, if we look at this vascular function curve, if you assume that the vessels are remaining the same, if they have the same exact compliance, well, an increase in blood volume increases the static pressure, right? So that's what you're seeing here. This is normal, right? So this is when cardiac output is 0. By adding more blood, obviously, you increase blood volume, you increase blood pressure. So that's what you're seeing, is that this curve, when you add blood volume, looks pretty much the same, but you are seeing an increase in pressure due to the increase in static pressure, right? So you do increase the maximal cardiac output. before you get to a central venous pressure of 0. And then hemorrhage, a loss of blood, is going to work in the opposite manner, right? So what you're seeing, this shift in the vascular function curve, that's due to the decrease in blood volume, ultimately, which decreased the static pressure. And so, therefore, you would see a decrease in the max cardiac output before you reached central venous pressure of 0. So ultimately, blood volume, adding more, you're going to be able to increase cardiac output and pressure. By subtracting more blood, decreasing the blood volume would reduce cardiac output and therefore pressure. Now let's talk about events that could occur within the body that ultimately lead to similar results as changing blood volume, right? So we're going to leave these two terms here, transfusion and hemorrhage, and describe what happens when you change the size of your veins, when you either increase or decrease venomotor tone. And so remember that, throughout the, lectures, I've been saying vasoconstriction and vasodilation. Typically, when we say that, it refers to the arterial side of circulation, although, vaso is going to be the prefix for vessel. However, most of the time when we talked about vasoconstriction and vasodilation, we were talking about the arterioles, the resistance vessels. However, veno is going to be specifically for the venous side of the circulation. So venoconstriction would be a constriction of the veins, therefore taking it from, a vein with a larger radius. Venoconstriction would be then decreasing the radius of that vein. As far as the math is concerned, it remains the same. This would increase resistance and therefore increase pressure within that vein. Venodilation would be going from, let's say, this normal size vein here, whatever you want to call it, to a larger radius, right? And that would do the opposite. That would drop resistance and therefore drop pressure within that vein. And that's sort of what you're seeing here if you had a constant blood volume. When you have venoconstriction, right, you are seeing a increase in pressure, right? So because we are decreasing the radius, we increase resistance, and therefore we increase the pressure. If we venodilate, right, we are decreasing the resistance within this vein, and therefore decreasing the pressure within this vein. So ultimately, changes in venomotor tone are going to have effects on static pressure, right? And so, since we have more blood volume in the arteries and veins, this is ultimately going to affect this relationship between cardiac output and central venous pressure. Because ultimately, once we start changing the size of our vessels, we're going to start to change blood flow. So if we increase venoconstriction, it behaves similar as blood transfusion, increasing blood volume, that we're going to see an increase in static pressure within that vein. And if we decrease venomotor tone, if we venodilate, that's going to decrease pressure inside that vein and ultimately decrease this static pressure. So now what I would like to do is tie in this last slide, sort of the function that we were talking about with venoconstriction, to how does it increase preload? How does venoconstriction ultimately lead to an increase in central venous pressure, right? So let's start off first that venoconstriction varies from region to region. In areas like the skin, the liver, and spleen are blood reservoirs, meaning these are highly compliant regions of the body. Remember that compliance is going to be equal basically to volume over pressure, right? So they hold on to large volumes of blood, right? So you can see a lot of our blood volume overall is stored within the venous circulation of these areas of the body, right? So again, let's talk about venoconstriction and what effect it's going to have then on preload and cardiac output. Let's say, this is the right side of the heart. This is our right atrium right here. We know there is vena cava. Let's just use the superior here. The superior vena cava, is going to have blood dumped into it by the many veins, and the venules, are going to be the ones that help dump blood from the capillaries, right? From the different capillaries surrounding the body. It goes into the venules. I'll just abbreviate that here as VEN. And then this is all the capillaries, right? When you look at pressure throughout the systemic circulation, we know that it starts highest in the aorta, in the arteries, and goes down as we go from the arterioles, the capillaries, the veins, and then the vena cava, right? So the pressure here in the capillaries is greater than the venules, and the venules is greater than the veins, and the veins are greater than the vena cava. And that's what allows blood to flow in this direction back to the right atrium, right? And so now as preload is concerned, what does venoconstriction have to do with it? Well, if we take a vein from a radius, its resting radius, and we venoconstrict, like we said on the last slide, pressure is going to go up, okay? So now pressure is going up when we, I'm going to decrease here the size of this vein. Pressure is going up. And remember, flow is going to equal the pressure inlet, or starting, minus the pressure outlet. So what is preload? It's basically the venous return back to the vena cava, back to the right atrium. And so if this stays the same, if the pressure of the vena cava and the right atrium stays the same, but venoconstriction leads to an increased pressure in the veins, what ultimately we're going to see then is an increase in flow from the veins to the right atrium. And we know when we increase venous return, we increase flow back to the right atrium, we increase preload. So by venoconstricting these blood reservoirs of the body, the skin, the liver, the spleen, we're able to redistribute some of that blood flow back to the heart. And this is one of the mechanisms that the body is going to undergo in order to make sure that we can keep preload and central venous pressure up when there is an increase in cardiac output. Because remember, when we increase that cardiac output, if nothing changes, we're going to see a drop in preload, right? Because these compliant regions, areas like this, that increase in blood volume is going to wind up here and not make its way back to the right atrium. But if we venoconstrict those areas, well, then we are able to keep up with preload, and then we're able to keep up with the level of cardiac output. So this is one of the mechanisms used in order to keep up preload when there is an increase in cardiac output. Vaso and venoconstriction are going to be very important during blood loss. So let's say you had a pretty bad cut, right? Don't want to bring up, obviously I'm not going to show an image or anything like that, but you can imagine in your head, if you have a cut. Let's say you were cutting something in the kitchen, you accidentally nicked your finger. There's going to be blood flow that is then, there's going to be blood volume that's lost out of that cut. And so basically this hemorrhage, in order to stop a bunch of negative things from happening, well, first you are going to vasoconstrict to that area of blood loss, right? You're going to try to slow down the flow of blood to that area. And then you're going to venoconstrict. So in order to, by doing that, basically what you're doing is helping to redistribute that blood to more vital organs, right? So by vasoconstricting, that's why you are seeing the pale appearance around that cut, because basically the body's cutting off blood flow to that area, right? And then redistributing the blood flow in, the veins to more vital organs, the heart and the brain, because we're seeing a loss in blood volume. So in order to make up for it, we're seeing some venoconstriction during that hemorrhage. To wrap this up, let's talk about the changes that the arterial circulation, changes in vasoconstriction and dilation or peripheral resistance can have on this vascular function curve. So remember that there's very little blood volume that's stored in the arteries. Again, most of it is stored in the venous circulation. So when you have a change in total peripheral resistance, either vasoconstriction or vasodilation, you're not going to see big adjustments in the static pressure, right? But what happens is that when you change the size of the arterioles, ultimately you're affecting that arterial runoff, the amount of blood that's heading towards the venous circulation. And then therefore, you're sort of limiting the amount of blood flow that can make it back to the heart. So when you have vasoconstriction, there is an increased arterial blood volume pressure and then a decrease in venous blood volume and pressure, right? So when there is an increase in peripheral resistance in the arterial circulation, more blood winds up in the arterial sides, less winds up on the venous side, therefore decreasing venous pressure. So we're seeing a shift here of this vascular function curve to the left. The opposite then would hold true, so if you vasodilate, more blood volume is heading towards the venous circulation, and therefore that increases the likelihood that some of that blood volume would head back to the right atrium. So you see that rightward shift, right? And so here, we're assuming that cardiac output, that blood volume and venous compliance are constant, and these adjustments, the size of the arterial vessel radius is ultimately impacting the arterial blood volume and then therefore the venous blood volume. So that's it. We talked a lot today about the effects of cardiac output on central venous pressure or preload. And we talked about the influence of blood volume, the influence of venoconstriction, the influence of peripheral resistance on how it affects that vascular curve. But ultimately, increases in cardiac output will decrease preload, and decreases in cardiac output will increase preload. And that all has to do with the compliance of the veins. So if you increase the amount of blood volume heading towards the veins, ultimately more of that blood gets stored and less makes its way back to the right atrium. But ultimately, that would affect then cardiac output in the future, because what you're going to start to see, right? So if we increase cardiac output, what that leads to is to a reduction in preload. But we know that with reducing preloads, that's ultimately going to lower cardiac output. So if we want to keep cardiac output consistently high, we need to do something in order to restore preload. Otherwise, cardiac output is going to drop in the beats and the minutes following, right? And so we talked about one example today. We talked about venoconstriction. We talked about venoconstriction, so changing the size of the venotone, venomotor tone, in order to help to redistribute blood. But in the lectures to come, we're going to talk about a couple of more mechanisms as well, including the skeletal muscle pump and the respiratory pump. And this is going to help when cardiac output increases, and like during exercise, the skeletal muscle pump and the respiratory pump are going to help to keep preload up so we don't see that reduction in cardiac. Thank you guys so much, and I'll see you next lecture.